Okay, this is a routine toric implant video. It's an unedited video. I'm just doing a voice overlay. The purple marks there were created when the patient was sitting upright. I use a marker that's made by Mastel that has a bubble level on it with three prongs at 0, 180, and 90 degrees. I make the mark a little darker with the marker on the sclera, and then under the surgical microscope, I use this uh, marker to mark the alignment axis of the implant. And that mark right there is just to make the 0, 180 degree axis slightly darker for the implant or for the incision. I coat the eye with viscoelastic. That keeps the eye from drying out, and then a few drops of BSS will smooth that out so that your view is good. The surgery is pretty routine. There's just a 1 millimeter paracentesis. I'll use some BSS and epinephrine and lidocaine for comfort and pupil dilation. We use the Duet viscoelastic system from Johnson & Johnson, so this is Endocoat, a dispersive viscoelastic. That Q-tip I use just because it'll stabilize the eye and is atraumatic. This is a 2.4 millimeter keratome. I extend the incision slightly, otherwise I get a little bit oar-locked with the sleeve on the phaco tip. These are Utrata forceps that are used to initiate and complete the capsulorhexis. This is just a fairly standard technique. I use the Akahashi tip on a cannula for hydrodissection. That has a pretty nice angle and helps me get a good fluid wave and mobilize the lens. Once it's mobile, then I'll switch to phaco. We use the Johnson & Johnson phaco machine, which has both a peristaltic and a Venturi pump. I generally use the peristaltic for the sculpting mode and then the Venturi for everything else. It's very efficient. My second instrument is a Singer sweep, which was designed as a capsule polisher, but I use it for the whole case. That angle at the end helps me get into the grooves and crack the lens really efficiently. It's very comfortable to use, and it has a rounded blunt tip, which is pretty capsule friendly. I believe the company that makes that instrument is Epsilon, but I've been very happy with it. I've been using it for years. Nuclear disassembly is pretty standard divide and conquer technique. You can see with the Venturi system, it's very efficient. Irrigation aspiration is used. We use this Alcon polymer tip at this surgery center. Again, very capsule friendly. And I use the Venturi pump. I just find that it's more efficient and easier to get the cortical remnants out of the capsular bag with the Venturi pump. Right there, I'm just using the tip of that IA handpiece to manually remove some of the cortical wispy material on the posterior capsule. This is just regular Helon into the capsular bag, and this is the Singer sweep again, doing some anterior capsule polishing. Again, I was always taught that removing the epithelial cells from the anterior capsule will facilitate the healing process, because that's where the epithelial cells are what make the inflammatory cytokines and cause stuff like anterior capsule fibrosis, phimosis. So if you remove as much of that as possible, it's helpful. The funnel for that inserter goes all the way into the anterior chamber. Delivery of the implant is very easy that way. And then I try to get the toric marker, the alignment markers, 10, 15, maybe 20 degrees off set there. You can see I'm going to want to rotate that clockwise when it's time to do it. I'm hydrating the incision here to maintain anterior chamber stability. That is dexmoxy going into the vitreous cavity. And so if I have the incision hydrated and the viscoelastic still in the eye, all of that dexmoxy ends up in the vitreous. For viscoelastic removal, I just go behind the implant at first, and then I will sweep the angle, all in an effort to prevent IOP spikes. And then once I've cleared the chamber of viscoelastic, I try to rotate the implant to be on axis. It's easiest to do this with continuous irrigation because that allows enough movement of the implant so there's no stress on the capsule. Once I've got it aligned, I'll actually turn off the continuous irrigation and tap down on the implant and just hold it there for a few seconds, and that will it sort of sticks the implant to the capsule so there's no rotation. Hydrating the incision here is just my normal wound closure. Do that for all three, and I use a Weck cell to pull the fluid out of that interface. That works pretty well most of the time. I mean, I'm actually applying some pressure there, trying to oppose the endothelium to the rest of the stroma. But you can see the incision closes pretty efficiently. I think that when you do it that way, the risks of having an issue go down. I'm just using this this ring to confirm the alignment of the axis of the implant. It's hard to tell in this video because the microscope is offset, but that under the surgical microscope, that implant is aligned properly. And so it didn't require any additional manipulation. That is Kenalog, a dilute Kenalog going under the conjunctiva for the dropless surgery, and then we are all finished.